Welcome to the High Performance Hockey Podcast. Today we're joined by the founders of Resilient Performance Systems, Dr. Doug Kechijian, Dr. Trevor Rappa, and Dr. Greg Spatz. Doug, Trevor, and Greg are performance-based PTs and the founders of Resilient Performance Systems. Resilient seeks to systematically explore the continuum between acute rehab and athletic performance. Resilient's clientele include athletes and operators from MLB, the NBA, the NFL, and professional mixed martial artists, X Games winter and summer Olympians, the NCAA athletes, federal law enforcement, tactical teams, military special ops, and those with a history of persistent pain and extensive surgical backgrounds. Resilient also advises organizations about medical and performance staffing, program development, and injury risk mitigation strategies. This is a really interesting conversation from really gentlemen that I admire in this industry. They're a combination of critical thinkers, physical therapists, strength coaches. They do a little bit of it all. I think of them as all as Swiss Army knives, really, really smart individuals. We talk about the current state of physical therapy. We talk about the Wild West, as we call it, end-stage physical therapy. And lastly, we have a really in-depth and unique opportunity to learn from a case study. It's a fantastic episode. Welcome to the podcast. Welcome to the podcast, gentlemen. Thanks so much for joining us.
Thanks for having us on.
Of course. I kind of want to start with Doug. It's an off-the-cuff question. I realize I sent you guys questions in advance, but the first time that we all met, actually, was a Robertson Training System seminar. This was a long time ago, guys. We're talking 8-9 years ago. Unbelievable seminar. Like, some amazing people spoke. Doug, but I vividly remember you. You were talking about a case study, and you mentioned it. You prefaced to the audience. You said, I think we need more case studies in strength and conditioning and performance. Not so much of why things work, but why things fail and how we iterate. I thought, when I heard that, I thought, that is literally the essence of learning, and we need to do that more. Really, thanks, for sharing, but do you still agree with that now, 9-10 years down the line? Do you still think we need more and more of that?
I would say, yeah, now more than ever. I mean, when it comes to speaking it like theoretically, most people agree on some of the core principles of strength and conditioning and rehab, but how do you kind of execute those principles? Like, how do you operationalize certain variables? What does that look like in practice? And, with most coaches or, medical providers, like, we can look at their programming and kind of know what they're about. It's one thing to say, I believe in these things, but when you look at the paper and maybe like how they coach a movement, how they adapt their programming on the fly, I think that's much more representative of how they think than them trying to, or maybe like articulate how they would write a program. It's the whole, like, show me your portfolio thing. You can come up with your investment model, but I want to see, what do you do with your own money? And
sure,
like our programs, our case studies, that's our money. That's our portfolio right there.
Outstanding. Trevor, I want to ask you a question, and please, guys, feel free to piggyback on this. Resilience Performance Systems. Looking at the website, looking at the mission statement. This is the mission. Normative, in quotes, movement and physical function in medicine do not reflect your goals. Resilient believes you are capable of more. How did you guys come up with that mission statement? Define normative, and what is more?
It's a great question. So I think, like, for all of us, we all had a strength and conditioning background before we all met up in PT school. So I think we always kind of came into the rehab and the physical therapy world with that lens of like higher levels of performance. So if you were to Google physical therapy and see what images pop up, everyone kind of knows just the basic ADLs, activities of daily living that pop up in those pictures of physical therapy. So the clients that we search for and the clients that we want to treat are looking for more than that. They're not looking just to be able to walk around and not have pain, which is a great goal. But for us, we're looking for the people that are looking for the higher levels of performance, whether they're high school, college, pro athletes, weekend warriors, whatever it is, that are looking to get more done physically. So the discharge criteria for physical therapy is pretty low. It's being able to do basically just your ADLs or walk without pain, complete X flight of stairs without discomfort or limitation. So for us, we're looking again to kind of push the envelope and help people achieve their higher level physical goals, which can be sprinting, running, jumping, cutting, all that different kind of stuff.
It's going to lead right into my next question. And Greg, I'm going to send this one to you, but it's more of a comment, and then I'd ask you guys agree, disagree, and then please expand. And this goes for everybody, but Greg, I want to start with you. Great strength and conditioning coaches are physical therapists, and great physical therapists are great strength and conditioning coaches. Agree, disagree, expand.
Yeah, no, absolutely. Like there's definitely, different, scopes of practice for each like standalone profession, but there's a huge gray area. And that's, I think, what we strive to do the best at is kind of turn ourselves into strength coaches, start from day one post-op rehab and take them as far as we can along the continuum with whatever sort of constraints or, maybe financial or insurance barriers we might come across. We still try and finish with these people as far down the continuum as possible, because just kind of piggybacking off of what Trevor says, like, you don't want to be in physical therapy and just be doing light band exercises for the end till the end of time. Like, you want to be off the table, you want to be on the gym floor, you want to be running fast, jumping high, all of those higher performer sort of things that everyone wants to be able to do as an athlete. And that's, quote unquote, more of a strength and conditioning sort of thing. So for us, if we can turn ourselves into a strength coach as somebody's rehabilitation, I think we're going to do them a much better job of transitioning back to practice with their teams or even competing with their teams at the next level. And that's our goal. And I think a lot of times, like, the athletes that truly like see the value in what we're doing are the ones that we can take through that entire process. And their sense is that, like, this is different. This is, this is more than just rehab. This is more than just physical therapy. Like, I'm able to do a lot of higher level things. And oftentimes they're like, I'm better than I was before rehab, which is the ultimate goal for us.
We have lots of interns that come in specifically in the summer at our facility, and many of them actually, their end goal is physical therapy. And I tell them a lot. I say, guys, this is massively important for you to build your acumen one day in PT. I said, the adequate progressions, regressions, understanding physics, lever lengths, torques, healing timelines. This is only going to help you in that toolbox down the line and in physical therapy, if that makes sense. When you look at interns or young professionals, do you recommend a background, or would you prefer a background in strength and conditioning?
Yeah.
Is that something that you guys look at when you guys look for interns?
Yeah, so we have students all the time, and we always try to do some sort of interview process or get the resume before we actually see them. And the ones that have some sort of strength and conditioning, personal training, some sort of fitness background, even if they're just a college athlete, makes a huge difference in terms of being comfortable with the population that we treat and understanding, like, especially here in Jersey, we see so many high school and college athletes from day one post-op getting back onto the field for whatever sport they play. Understanding those kind of mid-stage to late-stage progressions, which is really rooted in strength and conditioning, makes a huge difference. And like, for us, they're able to kind of be very useful for our population that we work with, which is huge.
Yeah, and definitely, like, I always recommend for any like high school kid, undergrad student, that they do a strength and conditioning internship, even if the end goal is physical therapy, because I think that's just something that's so invaluable. And we've all gone through that process in different ways, ourselves. And I even just recommended it last week to a kid who's an undergrad, baseball player, wants to go to PT school. And I told him, like, most important thing, you have to do this internship as your undergrad. I highly recommend you do not go to a physical therapy clinic and just kind of be an aide in that setting. Like, you should, seek out a strength conditioning facility that's going to push the envelope of what rehab can be for you. And that's huge for us.
Doug, this one's posed for you. The hunting license, as I call it, right? Oh, well, you're a CSCS, you're a PES. Is there a need for the DPT, quote unquote, education or certification? Can you get that in a mentorship model, or is that something that's necessary for the profession?
That's a great question. And I know that we both are fans of Econ Talk. So I feel like I'm doing an Econ Talk episode now, because obviously it's a very deeper question when you kind of unpeel it.
Yep.
And it makes me want to go back a little bit for some context to some of the other questions you initially asked. So the first one is, like, what is normal? What is normative movement or whatever? Well, who defines that, right? So in our healthcare system, really the discharge criteria is not necessarily defined by the consumer or the patient. It's defined by a third-party payer, which means that, unlike most other service industries, we don't really have a market, and we don't have true competition, because people don't really, like, choose their health insurance. It's kind of like dictated by their job, and people typically pick their job based on the salary, their what they want to do for their career, not because this company has the best health insurance per se. I mean, it might be a small part of that decision, but it's not driving the decision. So who defines normal? Typically, the consumer would say, this is what I want out of this experience, and people would compete to provide the best experience possible. That doesn't happen in physical therapy, traditionally in the insurance-based model. And then we talk about like physical therapy, strength and conditioning. These are artificial distinctions. I mean, all that really matters is in the sports medicine or rehabilitation sense, you have somebody who has some kind of an injury or pain. They want to get from point A to point B, and somebody has to help them get there, or multiple people. But there's just a certain level of knowledge and experience that's required to get them from point A to point B. Who does that doesn't really matter. It becomes semantics. What's strength and conditioning? What's physical therapy? And like, I'm not necessarily, even though I have a background in strength and conditioning, I'm not claiming to be a strength and conditioning coach, because that's not my professional identity. I'm a physical therapist, and that's what I'm like certified to do. But I don't want to like insult anybody, a coach who's like, well, you're not actually a coach. But even though I might do things that look like that, I'm not in front of 50 athletes in a college setting coaching them. I mean, that's a really hard job, and I give anybody credit that does that. I'm not doing that, even though I might take things they would do to help with the athletes that I work with. But to answer your question about the certification, and I'm, we were talking about this, Greg, Trevor, and I, before we like how we're going to answer this. And I'm like, well, if it was 200 years ago and I was a blacksmith, chances are my father and grandfather would have been a blacksmith in the village. Everybody in the village would know that, this family, they have a history of being good blacksmiths. They're trustworthy. They provide good care, right? High quality work. And so it wouldn't be necessary for us to get a certification, because our reputation would precede us. And it's the kind of thing where, if you don't do a good job in a small community, like your people will take their business elsewhere. I mean, now we live in a much different world where if you're trying to run a business, you need to be accessible to a lot of people, not just those in your kind of immediate circle. And, because of liability and just, you don't have the ability necessarily to vet every single person. You have to rely on some minimum standard of credential. And that's like, Russ Roberts talks about occupational licensing, and do we really need people to be licensed by the state to cut your hair? Like, probably not. And a lot of times when people argue over these things, it's not because of safety or quality, it's because they're trying to protect market share, and the people who have the licenses try to exclude other people to minimize competition. But I think in healthcare, because living in the real world, sure, like maybe there's a minimum standard. I mean, I think that beyond the minimum standard, I don't necessarily like a lot of the Con Ed requirements. I think that's really more of a kind of a money grab, and it's one more metric to gain. I think people who want to learn are going to learn. And, I think a lot of times, like if someone's a really bad practitioner, for safety reasons, or the market will kind of phase them out if they're really bad. But yeah, I mean, does someone need to get a DPT, like need from a knowledge standpoint to be an effective practitioner? Like, I think the answer is probably no. I mean, if you gave us somebody, a student or an intern, and they had like a year to work with us, we could probably create a curriculum and teach them what we think they need to know for our model. And at the end of that year, they'd probably be further along than what 3 years of a DPT program would do. But at the same time, like, we have to answer to somebody. We have to answer to the state boards and, some of the other sort of like legal type of parameters. So I think that there probably has to be some kind of a minimum barrier to entry in the form of a certification. But I think consumers and patients and athletes should know that it's really just an entry point, and it means nothing. It's just one more thing that people are kind of going to gain, but the people that want to differentiate themselves are going to have to do way more than that.
Excellent response. Greg, I want to shift this one to you, and guys, feel free to chime in. Cash-based business model. What are the challenges of that? Now, I want to give you guys a little bit of background. I know it's different in every state, but we'll give you an example here in Ohio. It's very difficult. So we work with a large demographic of hockey teams. Those organizations have teamed up with larger institutions such as universities, big outpatients, and have teamed up with their physical therapists, right? What happens is that lost leader model is they are marketing as a free resource, but the moment the athlete gets injured or has a surgery, well, their doctor is going to be doing the surgery, and typically their physical therapist. That's a massive challenge in Ohio for cash-based small business. Do you see such challenges like that where you live? And if not, what are the challenges of a cash-based business?
So I think just moving back to like when we started this business, we wanted to provide the best service possible, and obviously what was most practical for what would kind of be expected. Like, you know, we're not going to expect to spend 3 hours with somebody in a given day. Most kind of personal training or strength and conditioning sessions are an hour long. We felt like an hour was, you know, plenty of time to get in a lot of good work. So that was kind of what we focused on, was, okay, we want to provide an hour of care for all of our patients, and we want to do it without kind of delegating and being there for all of it and providing what we think is the best service along that entire rehab to performance continuum. So for us, we built that model in our heads, you know, based off of other people are doing it. We weren't the first to do it. And then we tried to build in, and it started, we were only accepting cash when we started. We didn't really learn very much about the options of insurance, other than the other end of the spectrum, where we knew we didn't want to see 4 patients at a time and kind of have a higher volume model. So then, you know, we learned a lot more about the out of network insurance benefits that some people have, and how that could help a lot of patients just access us, because being cash based definitely limits who you can work with. Just from a financial standpoint, it's not easy. And I know, like, it would be hard for myself to even access my own care if I needed to financially. So regardless of which route you go, there's definitely still limitations in how much you can access your care, because if you're going the in-network route, you might only be given, you know, a certain number of visits specifically by the insurance company that will end at a certain time. However, if you're going the cash route, you can see people unlimited, but it's obviously not unlimited because the cash route is expensive and there are limits to people's finances. So for us, we like to just be extremely transparent with how we can provide our services from a financial standpoint. We tell people upfront exactly what they're expected to do, or expected to, you know, put out of pocket, and we go based off of that, and we give them what they need, and try not to give them something in excess, let's say. So we want to see people for as much as they need, and not more than that, and try to refer out to other professionals like strength and conditioning coaches or sport coaches, wherever that fits. I think I kind of went on a little bit of a tangent here. Did that kind of answer part of your question? And then Trevor and Doug can chime in too.
Yeah, I think Greg kind of hit at it, where it's like, regardless of whether you go an out-of-network, a cash route, or an in-network insurance route, like, there's limitations to each, whether it's like the amount of time you have with your patient if you're an in-network physical therapist, or if it's just like whatever financial resources, whether it's the patient paying for it themselves, or just the number of sessions that physical therapy is going to be covered by the insurance company. Like, we've had kids where, you know, they're post-op ACL or Tommy John or whatever it is, and their insurance is going to pay for 15 sessions for the entire year. Like, it doesn't matter who you're working with. Like, that's just not enough physical time. Even if you're spending 1 hour with the kid, all 15 sessions, that's just not enough time to take somebody through the progressions that they need to get back to whatever they're kind of looking for. So I think that also kind of goes back to like your normative thing. If you have a soccer player that tore their ACL, what they need to get back to be able to play soccer is, you know, say you have 60 sessions with them. It doesn't really matter if the insurance says that they're good to go back to play soccer once they have, you know, equal quad strength and they have their full range of motion and they can, you know, run 1 mile at a jog pace. If that's all the insurance is going to pay for you as a physical therapist to kind of do, then there's still like this huge gap between where they're finishing physical therapy and being discharged to when they are actually going to be able to be on the field and be safe and, you know, be effective for their team. So there's such a discrepancy sometimes between what the insurance and what is going to be covered by it, and then what we're able to do with them within our session. So it's like, regardless of whether you have somebody who is a cash person or you're going through somebody's insurance, just some sort of limitation. And what we try to do, like Greg said, we try to almost be like the point man for those clients and help them get what they need, whether it's with us, whether it's working with their strength coach at school, whether it's working with their private strength coach on the outside, to make sure that they're kind of getting that continuous care, even if it's not from us, just knowing that they're, you know, there's still some steps that they need to go through to be able to get back to their sport. We're trying to make sure that we are helping the patient be educated in that regards, to be able to work with who they need to in whatever way is accessible and feasible for them to be able to get all of the different things that they need.
Anthony, if I could just add one thing to that that's important to differentiate. People associate physical therapy with post-operative care, but not all physical therapy is post-operative. I think in a post-operative case, that's when athletes or patients typically do need physical therapy 2 or 3 days a week, especially early on. But I would say most people we're seeing are not post-op. They might have, like just some anterior knee pain when they walk down the stairs or do something, but they're still kind of doing what they want to do, but they have some awareness of their knee, or they have some back pain, but it's not so debilitating that they can't do certain things, just more of like an annoyance. For those people, we might only see them 1 or 2 times total and just give them things to do on their own. So even though maybe our upfront price, our hourly rate is higher than what a copay for a single in-network session would be, ultimately it might work out to be the same thing. And we also value people's time just because of the nature of in-network insurance reimbursement. If you're an in-network place and you're authorized 9 visits for anterior knee pain, what are the chances that you're really going to discharge the person before those 9 sessions are up? So there's an expectation in physical therapy that, well, if you come here, you've got to do it 2 or 3 days a week. But I mean, we're all busy people. Like if I went to the dentist and the dentist said, you have to come in 3 days a week to get your teeth cleaned, even if it was free, I'd be like, well, I can't do that. Like I'm not doing that. So give me a way to take care of my teeth on my own while I'm here, utilize your expertise in a way that I can't access. But beyond that, like what are some strategies? So that's often what we're doing with people. And most people don't need a ton of one-on-one, multiple times a week care. If we can just identify like some of the main problems and then triage and find what we think are going to, give the highest ROI, that can be very, very powerful. It doesn't take a lot of time, and, it saves them money too at the end of the day. So having that pressure of like, this person's actually paying out of pocket, that almost makes it more authentic, where we're like, all right, we have to give this person what they need right away because they can't be here forever or indefinitely.
I want to pivot slightly if I could. Is there anything to add? Sorry, didn't want to cut anyone off.
I was just going to add one last little thing,
Sure.
because you kind of mentioned it in regards to like hospital systems that are in control of some of the hockey teams by you in Ohio. Like one of I'd be interested in your response too. It's like, I'm sure some of those hockey teams have their own strength and conditioning coaches. Like, how do you kind of get access to those players? And like, one of the things that's just been huge for us is we just try to be as good as we possibly can and give the highest quality service that we possibly can. And like, that has differentiated us in this area. Once we work with one kid from one high school, they have a good experience, and word of mouth kind of spreads like wildfire. And then we start getting access to some of those kids, even though like one of the local physical therapy chains that has 25 clinics in the area, maybe like the sponsor or send their ATs to work at that high school, and they have, like they know those people, but because they know kids that have gone to that in-network place and they're going 3 or 4 days a week, like Doug said, and they're, they have anterior knee pain and they're being seen for weeks on end and not getting back to play their sport. But then those kids come and see us for a couple of sessions, and we hopefully give them something that's a little bit more actionable to hopefully make a difference with what they're dealing with. Then they get back on the court quicker. So for us, it's like, there's a lot of things that are not in our control. Like we don't have the financial resources that some of the giant corporations do out here, but what we do have control of is providing as high of a quality service as we possibly can. And that really has helped us differentiate between what we do and how we operate compared to some of the other, more in-network places that we kind of compete against sometimes.
People, principles, process, provisions, and results, right? That's outstanding. Probably one of the most powerful for our small business is word of mouth. And again, that comes with results and building a good environment. I want to pivot slightly because this last conversation we had all involves some sort of talk about end stage rehab. So one of my mentors, Dan Pfaff, he talks about injuries and the cause of injuries. And I know it's very, very complex. 4 broad-based, poor biomechanics, poor lifestyle, poor training, and end-stage medical, clearing someone too quickly or not having the requisite markers. Dan actually calls it the Wild West, right? You're cleared, you can do your SLDLs, you can squat. Oh, great. Are you ready to hit the ice? There's a gap there, massive gap. I've heard you, Doug, use the analogy of passing the baton. Maybe it was you or Stuart McMillan. I don't know. It was one of the two. These passing the batons is the difficult part in this process. Passing the baton from the doctor to the physical therapist, passing the baton from the physical therapist to the strength coach, passing the baton from the strength coach to the on-ice skill coach, passing the baton from the skill coach to the head coach for practice. Doug, this is you, and this is a difficult question, but why is there such difficulty passing the baton?
Well, I don't know if I think a lot of people want to pass the baton to somebody else. So
fair enough.
But I think what your question is getting to is, has the baton been passed at an appropriate time, right?
Fair enough.
The problem is, and admittedly, this is no one's fault. I mean, it depends on the situation, actually. But for most people, right, who don't work in like a collegiate or a pro setting, like in an outpatient physical therapy setting, who's really in charge? I mean, is it the surgeon? Is it the physical therapist? Is it the sport coach at the high school? I mean, like everybody's got busy lives. No one explicitly entered into an agreement where they said like, okay, like we're a part of a team that's going to, try to work together for the betterment of this athlete. Like we work for our own company, the school, they're paid by somebody else, the surgeon's paid by the hospital, and we all try to do the best that we can, but there are kind of like limits to what we can all achieve, even with the best intentions, when we're employed by different people and we're working separately and we all have our own caseloads. And so it is a difficult problem. And so I don't want to point the finger at anyone or anything. I think in a pro sports or a collegiate sports setting, like that's why you have performance directors, right? Because presumably they're supposed to be the ones that are kind of the conductor of the orchestra and making sure that nothing gets missed and all the instruments are playing at the right time. But I think, in a lot of settings, people look at it like, well, I did like physical therapy. Again, I'm generalizing. I'm not saying this is true in every case, but well, we did our job. They have full range of motion. They've got a decent limb symmetry index. They look good in the weight room. So here you go, strength coach, right? And there's like no more communication. Because a lot of times, frankly, nobody wants the athlete getting hurt on their watch. And especially in the rehab setting, I mean, obviously, the greater the risk that you impose within the session, the greater the adaptation is going to be. There's no adaptation without risk. So a lot of times I think rehab people are a little bit risk averse because they don't want to be, because it's expected that people will get hurt when they're playing, even sometimes in the weight room, but it's not expected people are going to get hurt in physical therapy. And yet if we hand somebody over to a strength coach or a sport coach before they've been exposed to proper risk and we're saying they're ready to practice, then we're passing that baton on to somebody else and letting them assume all the risk. So I don't have a great answer for you as far as, like kind of why does it happen? And it's a complex system. So it's not like one person or one thing is responsible, but ultimately, I mean, there certain boxes need to be checked. Who helps the athlete, check those boxes? Like that's kind of context specific, and different types of leadership hierarchies and structures can emerge in different settings. But as long as there's at least some discussion of it and some acknowledgement that this is a multidisciplinary problem and somebody or multiple people have to take responsibility. I mean, I think a lot of times, like in our business, we kind of do that by default, just because our patients, it's so difficult to navigate the healthcare system. And they might say, well, I went to this orthopedist and they told me I need this, but I went somewhere else and they told me this, and then we're telling them something. And so I don't try to proclaim to be like the arbiter of truth with them, but I'll say, well, I'm going to try to help you reconcile what everyone's saying, but ultimately it's kind of your decision what you want to do. But if you have if there's something that I don't know, like here's somebody that I trust that can help you with it, and I can communicate with that person. And if he doesn't or she doesn't articulate it in a way that you understand, I can maybe try to speak more your language. So I think a lot of times we end up, because we spend the most time with athletes, being the quarterbacks, but someone kind of needs to do it, and it doesn't really matter who. But a lot of times I think just no one kind of takes that initiative, and then you have the batons being passed to these black holes where it's just a leap of faith from one practitioner to another. Very hard problem, right? Communication.
No, I was just gonna chime in and say, like, with our model, we are resilient. We are kind of under our umbrella, and we communicate with other umbrellas, as opposed to if you're working for a pro sports team, like Doug said, there's a whole team of people under one umbrella. So for us, like, we often, and in most cases, or a lot of times, don't really know who this person that we're working with is going to go to next. We don't know. We don't have a direct line of communication already set with them, or their sport coach, their skill coach, their strength coach. Like sometimes we just don't have the luxury of knowing those people. So for us, I think with our model, because we can spend more time with people, we try and just assume that everyone that they work with in the future is going to be incompetent. We just assume that, and we try to do our best job to kind of expose these athletes.
It's a great assumption. I like
being,
that.
Yeah, no, and it's not to say that we are, the elite and we know everything and we can help everybody, but it's more just, if we can't take on some of this risk and try and expose these athletes to what we could potentially see as a problem for them when they transition to a team or a skill coach, then they could be right back in our care and under our umbrella again. And I don't know if that's necessarily, doing your due diligence or just trying to do the best job that we possibly can for the athlete.
Yeah, that's not like Greg isn't saying that to like you said, to say that like we are the end all be all and we're going to do everything so perfectly. But I think the communication piece between each provider during those handoffs is what kind of ends up happening. Like we have it all the time where a patient like, oh, did my surgeon call you? And it's like, dude, I'm sorry, your surgeon's not going to call me. Like your surgeon sees 45 people a week and just did 25 surgeries this week. Like they don't have 20 minutes to call me and talk about you individually. Like it just doesn't happen. And even for us, whether we're transitioning them to a strength coach or to some sort of skills coach, it's really hard to actually have that true communication to help the next person understand where this athlete kind of currently is. So by helping, our job is to then get them as prepared as it could possibly be and kind of, give them as much strength and capacity and help those physical qualities as much as possible as they're transitioning to that next person. So they're as prepared as they can possibly be for whatever that next step is. And in the cases which we're very fortunate here in Jersey, like we work at a strength and conditioning facility, so we communicate with the strength coaches on a daily basis. Greg works at a pitching facility. That's where he's at right now. So he communicates with the pitching coach, the skills coach on a daily basis. When we have those situations, like those handoffs are significantly easier. I think things go a lot smoother because there is that constant communication, not just a one-time off communication, but we'll talk to them weekly about where that athlete kind of currently is. And that really makes the transition from, each phase of rehab to getting back on the field or on the court so much smoother.
I think what Greg said, sorry, is just so good. And
I do too.
I actually wanted to add that, and he beat me to it because look, the reality is we don't know what people these athletes are going to end up working with. So the heuristic is we have to assume that, like, look, if we're going to tell a high school athlete you can go back to football practice, I'm not going to assume that football coach read James Smith's book about load management and like how to blend the technical and the tactical and the strategic with the physical preparation. Like, and if you don't know a coach, you can't just be like, well, this physical therapist that you don't know calls you out of the blue and says, I want him to practice at 50% volume this week, and then we're going to ramp it up. As soon as an athlete is told they can practice, I'm going to assume it's going to be like, remember the Titans, and they're going to be like training like Marines in the woods and doing 2 a days, 3 a days. Now, we're not going to obviously have them do that in a physical therapy clinic. I mean, I think relatively speaking, they're going to be as prepared as any of their teammates. And if coaches are going to do crazy stuff, there's a certain leap of faith that even really good providers have to take. But I think that's a good, like I said, heuristic, is that just assume that when you don't have great communication and familiarity with other people you're going to be passing the baton to, assume they're going to be irresponsible and try to get that person as prepared as you can for that situation.
Couldn't have said it better, Greg. I think that's outstanding. Very important assumption. This Wild West, this gap that we talk about, and Trevor, I know we're going to talk a little bit more about a case study down the road, but I think, and this is just my narrative, and then I want to turn it over to you as physical therapist. I was uncomfortable with this area for a lot. For my first 10, 15 years in strength and conditioning, I've been at it almost 20 years now, it was the weight room, squatting, hinging. Now it's about many more working parts in unison, sprinting, getting on the ice, focusing on random and block practice, way more working parts, right? Obviously very difficult and messy to coach. Everything from coordination, power output, all that stuff where you eventually hand it off to a head coach. Do you feel that in your settings, did you guys feel that kind of as young practitioners and now growing into the profession? Did you feel that as well? Is it an education gap, a sport acumen gap, knowing more about the sport? Is it a confidence gap? I mean, I heard Boo Schexnayder a while ago talking about an ACL rehab that he did on a sprinter, and I was like, oh my gosh, man, he was aggressive with this guy, but he gets results, and he's done it year over year and has had more and more reps. Thoughts? Doug, could I hand that to you? Does that make sense? It's more of a comment. Did you feel that way as a young PT?
Yeah, I mean, I think that maybe the three of us, when we were in PT school, we had a recognition that like strength training and classical strength and conditioning was important. But even at that time, strength and conditioning as a field was more focused on like Olympic lifting and strength,
yes,
and not as much on maybe some of the more track and field influences. And that was definitely, I mean, when I started working more and seeing certain athletes and not getting results, and it's like, well, this person is strong, they look great on the table, but they always get hurt when they run. Why is that? I've got to learn more about running. And because my field hadn't solved those problems, I look to people like Derek Hansen and Boo and Dan Paff and the Altus people because they were already solving those problems. And what's funny, I mean, that's why we talk about Con Ed. Like, I will never get continuing education units for going to Derek Hansen's seminar or talking to the Altus people, but I would argue they've had a more profound impact on my development in the last couple of years than anything I learned internally in my field. So that's why we talk about like education. These things are very arbitrary. Like, who's to say that what they're teaching isn't valuable and worthy of an educational unit, but another, reading an EMG study and answering some questions in a journal article, that's going to get me. So it's like, I think a lot of the stuff is just so arbitrary. But I think, yeah, you make a good point that there's definitely, from like an athletic development standpoint, something that was missing from physical therapy and strength and conditioning. And, looking to sports like track and field and practitioners who maybe aren't explicitly, rehab providers, but they're kind of doing it because they work with fast people who strain hamstrings and they can't just like stop practicing. So what do? Right. And they've got to have a plan B, a plan C. Keba Tolbert from Harvard, he's got a great lecture on, like, I think he calls it plan B. Like, what do you do for a sprinter? But someone like that, they start with a template of, here's what I want to do with, a short sprinter or a long sprinter. And then if an athlete gets hurt, he's got a plan B and a plan C for all of his different, for his speed endurance day, for his speed day, for his tempo day, for his strength day. But because he already has a system, it makes it much easier to adapt on the fly. But a lot of us came into this, we didn't really have any kind of system at all. We were just flying blind.
Excellent. Gentlemen, Trevor, Greg, would you like to add on anything?
I mean, I think you're totally right. I like your point. It's like you're just uncomfortable with it. And I would say that was something I was uncomfortable with when we first started kind of working. And then, so like for a little context too, it's like when we first started Resilient, we were only in Manhattan. So 90% of our clients were just like Gen Pop adults. And then when we started practicing here in Jersey at a strength and conditioning facility, we started seeing like high school, college, and some pro athletes come through the door. So like, what we do for the people who have anterior knee pain and want to be able to walk around the city is different than somebody who has patellofemoral pain and needs to go play basketball at, a fairly high level. So that kind of showed us the gaps in our knowledge that we needed to have. And then finally getting reps through late stage return to sport ACL stuff, got more comfortable with what's normal, what's abnormal, what can we do, what shouldn't we do, all that kind of stuff. So really, yeah, it's a combination of identifying your own weaknesses, your own limitations and knowledge, and then who can we learn from? Like Doug mentioned, a ton of awesome track and field people. Like Lee Taff was instrumental for me in learning, well, how can I actually help somebody improve the change of direction ability, which is so huge for all field and court sports, and how can I safely take somebody through a progression of those kinds of activities so they are actually comfortable and confident when they get back to their sport. So yeah, it's like, being exposed to it, having reps at it, practicing it, learning more and more and has made a big difference in terms of getting comfortable with that end stage rehab, or that I should say more like the mid to end stage rehab. I think is where the baton kind of typically gets dropped, is that handoff from the PT to the strength coach, because there's this, PTs don't really do some of the plyometric progressions as well as some of the strength coaches do. Some of the strength coaches probably think that their clients have gone through the plyometric progressions, even though they haven't. So there's just that kind of miscommunication like we talked about.
Greg, anything to add?
Yeah, just to add on to that, like Andy Ryland is another person that kind of just comes to mind, just from, again, that end stage of contact preparation. And again, like we're not going to be exposing athletes to what they would actually go through on a football field or in a hockey game. So what can we do to at least try our best to give them some sort of chaos in their training and have them be more reactive in their rehab and their training, and kind of layer it into some of the other things that we would want them to do, whether it's sports specific or not, just kind of exposing them to some stuff that's a little bit more specific. But yeah, no, that's just another thing that kind of comes to mind for me.
I've got a question here that I added. Sorry, gents, late. This was a question that was sent to me from a really brilliant guy. If you haven't had the chance to listen to this podcast, I think, and hopefully I'm not trying to sell the podcast, guys, but Dr. Mal McHugh, he talked about the case against adductor testing for asymmetries. A long story short, I just had an interview with he and Reg Grant this past week, and he sent me a text afterwards, and it was an interview question that was asked on a total separate podcast. I don't know which one it was, but I said, you know what? I'm going to use that question. It's a brilliant question. And I think it's difficult to answer, so I don't want to put anyone on the spot. But Doug, I want to ask you to start. What is one intuition or assumption that you have about end stage return to play that greater access to data would allow you to test? And I'm warning you as you think about this. Mal told me, he said, Anth, this question was posed to elite soccer coaches, soccer strength coaches in the EPL. And he said it was a very big silence before one coach stood up and said, well, you know what? I think measuring defense is unquantifiable. And as you continue to think, I thought about this response myself. And I'm stealing a quote from Jerry Mueller. And I think the beginning of wisdom starts with realizing that there's limits to the possible, meaning not everything can be measured. like how many damn technologies do we need to have before we come to some sort of conclusion? Having said that, is there anything that you think greater access to data would allow you to test regarding any assumptions?
Yes, but not the things that we're looking at right now. So the typical answer would probably be, oh, well, you know, if I had force plates and I could look at limb symmetry and ground contact times and
Yep.
the thing is, you know, I think we have enough redundancy in our programming that yes, like testing is fine. You can do testing, but it's like, even if I knew somebody had a weak quad, when we're doing an ACL rehab, I'm doing everything. I mean, their initial rehab is like a bodybuilding program for their legs. It's like, let's blast your quad. I mean, we're throwing so much at them to try to develop those things that even if I had data saying this quad is weak, I literally couldn't do more to try to get it stronger. So it's not really going to affect what I do initially because I recognize that it's important. And we're doing, you know, double leg, single leg plyometrics. We're doing them both in the same session. So we're getting more intensity from the double leg stuff, less intensity from the single leg stuff, but maybe more desensitization because they're jumping on one leg, even if the output isn't as high. And we're using so many variations that if something is really a hole in their development, it's probably going to be exposed. I think from a data standpoint, if it was possible to measure, what would be the most helpful is we really don't know how to measure healing in the context of something like an ACL graft. There's been some studies. We're writing a book for Human Kinetics on return to sport preparation. I go through like all the literature on that. How we define healing is not that satisfying. How we measure it's not that satisfying. We're using, in many cases, animal studies. We're using studies in humans that have a lot of limitations that require people who have their ACLs reconstructed to have follow-on procedures. So it's a little bit of an artificial environment. We're using biopsy samples that are superficial, that don't necessarily correlate with function. Because without being too long-winded, if we really wanted to measure healing and we didn't care about ethics, we would take people at various stages of the recovery process and basically take the ACL graft to failure and figure out like, all right, like what's the point at which we have maximum strength in this graft? If there was a way to kind of look at and measure healing to say, okay, like the graft itself from a healing standpoint is as far along as it's going to be. Now it's on you as the provider to kind of just maximally develop function. That would be very helpful because I would want to know when and how are these tissues really at risk at various points along that continuum. So I know how hard I can push people. I don't know if we're ever going to get to that point because healing, even though it's a simple concept, it's actually very hard to measure ethically, right? But that would be what would help me the most. Not so much measuring performance outputs, but more that internal stuff. Like how are we really looking at healing and what's going on internally, so we know that like we're really being safe with some of this stuff.
Outstanding. Difficult question to answer. Gentlemen, Trevor, any thoughts on that question? Let me repeat it. What is one intuition or assumption that you have about end-stage rehab, and I might even say physical therapy, whatever, the healing process, that greater access to data would allow you to test?
Just thinking about like testing in general and then specifically with like we're trying to measure eccentric versus iso or concentric in velocities, and it's almost like we're trying to deconstruct like the ultimate goal, right? So if you want to play in a hockey match, you know, like you have to be fast. Like if you're not fast enough, you're not going to play. It's just like part of the game, right? Or if you can't get to positions to be in the way, you're not going to play. And that goes for any sport, right? So I feel like, okay, so if that's important and you can't play because you're not going to be good enough, like speed is a really important thing. Whether or not it's speed from eccentric contraction versus, whatever it is. Like, I feel like we're trying to deconstruct these bigger things that we already know of, like, all right, you got to be really, really fast. And I think I'm a good professional and I'm a competent coach that I can make people really, really fast. Just do that and do that really well and use extremely simple measurements of speed gates. And like I'm sure you've done like 1080 testing on the ice with guys. Like, you see these things and you measure these things, and it's like we can break it down into all these little finite, like little numbers and get more and more data off it. But I don't even know if that's doing us any good in the grand scheme. It's like, is it good or not? Is it fast enough or not? Is it strong enough or not? And those are like hard places to sit where it's like uncertainty a little bit and like there's no real answer to it. But that was what I was thinking about.
Real quick, just to piggyback on that idea. Sometimes, as Mike Boyle would say, we pick pepper out of fly shit. And I honestly think, like, I truly believe this, and I'm pointing my thumb. Like, do I honestly think that I'm going to improve one metric on a Hawken Dynamics 52 metric force plate, and this athlete's going to, oh man, we got him so much faster. His MRSI improved. I always say, well, what other thing's falling because I'm focusing on the other thing? What are the unintended consequences? I always say, and this is, again, econ talk, this is the Serbian sensation, Mladen Jovanovic, who I read, Gerd Gigerenzer, who's been one of the probably the most influential. Our programming is 1 divided by n. We diversify stress. We have small little incremental interventions that aren't facelifts. And we're not focusing on that piece of pepper in the fly shit. We're focusing on the big picture. And we compare them with our population, our team. If there's outliers on either side, then we're going to try to start focusing. But it's not a facelift. So thanks for your comments on that, Greg. I have to agree. And sometimes I'm guilty of it myself, picking that pepper out. But at any rate, great comment. Trevor, anything to add?
Yeah, I think for myself, when I think of my end stage ACL kids that I work with and things that I personally could do better is like, and I don't know if that would, like, having better time motion analysis, GPS studies of like, what are the actual game demands for whatever their sport is, just to be able to work on the capacity part. Like, one of the things I think I do fairly well is like the speed, the agility, the cutting, all that kind of stuff. But I don't know if I prepare my athletes well enough for the capacity that they're going to have to be able to, handle in terms of the sport. So like, one of the things that I always ask my kids is like when I was growing up, high school and college, if you were hurt, you didn't practice. If you were healthy, you're going to do literally everything at practice. It didn't matter. The trainer could say you have restrictions, but you're doing everything throughout the practice. So, in my head, I rely on that idea of hopefully the sport coach will be able to control some of the volume and some of the load for the athletes, which honestly probably is not always the case. So I think preparing my athletes better for the loads that they're going to encounter. So if I had info on like the total volume, the different speeds that they have to be able to run at, the number of change of directions, the types of change of direction, all that kind of stuff, I think would help me build a little bit more robust conditioning program for my athletes. I think that's probably one of the areas that I can do a better job of in terms of my end stage preparation. Cause I think in like most PTs, like they don't really do any speed. They don't sprint all out. They don't change directions. They don't expose to reactive chaotic environments. I do all that stuff. I know I probably can do a better job helping my athletes with the conditioning aspect of the preparation.
Excellent. It's final pivot. I want to respect everybody's time here. It is a case study. Trev, you're the man on the mission here for this case. But having said that, Doug, Greg, I'd like you guys to jump in as well in terms of like, yes, it may not be your case, but how that process evolves at Resilient, how you look at it through your lenses as well, because it's multidisciplinary and you guys all have very, very smart minds. But Trev, I want to start with you. Could you give us a brief outline of the injury that you rehabbed, the case study, and then I want to ask some follow-up questions. I know we're not going to mention any names, but could you just give us a kind of a footnote version of what you rehabbed?
Yeah. So it was a college football player who was referred to us by one of our best friends, who's a strength coach, Eric Manas, who had done his strength and conditioning, the previous couple of summers and while the kid was in high school. During one of his games, his wide receiver had a contact injury and like literally he tore his ACL, his LCL, both meniscus, and tore one of his hamstrings off of the bone as well. So it was just a brutal contact injury, like caught a slant, was turning upfield as his foot was in the ground, kind of got high load, lateral, very stressed on his knee and just destroyed his knee. So easily, like I have kids ask me all the time, like, what's the worst injury you've seen? It's like, dude, this kid's injury is the worst I've ever seen. Like, it's not even close. It's kind of crazy. I think he's an interesting case because there's so many orthopedics findings, so many, theoretical constraints that should impact all the different things that we do, because it's his hamstring, it's his ACL, it's both meniscus. Like, there's so many kind of things going on that ultimately, like, once the surgeon has done his job, which is, I think the surgeon did a phenomenal job of, it's like, there's really nothing I can do about it. The healing timelines and all that kind of stuff that we talked about are super important, but ultimately it's like, if this kid wants to get back to playing college football at his position, we have to understand the demands of what he wants to get back to and what are his current limitations, where is he at, like, on day one when I first saw him. So I saw him like a week or two post-op, and I worked with him till he left for camp over this, at the end of the summer. So I really got to see his entire rehab process play out, which was awesome. Yeah. So I think from our perspective, it's like, it's deconstructing, like, what are the final demands that they need to be able to do, where are they kind of currently at now, and how do we build them up there? So in my head, I think of, it's either wide receiver has got to be able to accelerate, max velocity, change direction, block, contact, all that kind of stuff. And it's what are the physical requirements for those different skills that he needs to be able to have. He's got to be able to have, all of the different types of strength, reactive strength, eccentric deceleration, max strength, all that kind of stuff. And then it's what are the angles he has to be able to apply force at? How do we then kind of prepare him for all those different things? So, like day one, it's really getting back his range of motion, making sure that his pain is as minimal as possible, getting back appropriate quad control, and then starting with the simplest strength exercises. Once he can do those comfortably, how do we get him to do the simplest plyometric exercises, and how can we kind of progress him safely along each one of those different qualities that we're trying to train? Because that's why the case study to us stuff is so important, because it's like what I just said. It's like, oh, that makes sense, right? You start simple, you start low force, you move the high force. You start low velocity, you move the high velocity. You start simple, you move the complex. That makes sense, but it's like, what does it actually look like on paper? And that's where we try to share some of that stuff on social media for some of those different progressions that we do, which is, the fun part of what we get to do is actually taking somebody through that progression from day one post-op to get them back on the field.
I think it also serves as a black box too, right? All the success, and then potentially some, in times, maybe there's something that's too aggressive or not aggressive, and you're able to iterate that and at least have that, so you can iterate it over time. My question is, in this case, right, that's a small car crash, his injury, right? Is the evaluation process essentially day one, I'm just trying to get some passive range of motion back? Or is there like a process that, I know it depends on the injury, but you pretty much saw him while he was handed off from the doctor. Is that accurate?
Yeah.
So you're literally trying to get passive active range of motion and then slowly building strength. Is that accurate?
Yeah, exactly. Yeah, exactly. So like day one, because he had bilateral meniscus repair, ACL reconstruction, his hamstring reattached to the bone, like he had his LCL repaired. Like there's so much stuff going on. So there's a lot more restrictions initially from weight bearing, range of motion, all that kind of stuff. So it's really just trying to operate within the surgical restrictions, the precautions, the guidelines that the surgeon gives me to be able to get back as much, range of motion as we can, get it like whatever constraints he give us, the surgeon gives us, how can we maximize his function within those constraints? That's really, so that changes depending on the surgery, the injury, all that kind of stuff. But yeah, it's pretty simple. It's like some easy manual therapy, protect the incision sites, let stuff heal, try to get out some swelling, get him moving as much as possible that doesn't, disrupt the healing in any way.
I'm going to ask a question here. I know this is not, Doug, your case, but Greg, I want you both to expand. Doug, I want to start with you. Okay, great. We've got the issue. We've got the surgery. We've got the passive and active range of motion. How do you decide? Because that, I would imagine, is much more controlled by the doctor. We don't want X degrees. We don't want this. We don't want that. Immediately, we want to protect the healing site. We want to slowly build motor control, et cetera. How do you make the decision of when to be a little bit more, air quote, aggressive? Okay, now we're focusing on more dynamic strength work. Now we're going to get to low-level plyos. Is it a combination of the existing research? Is it a combination of your experience? Is it a combination of other coaches and their results? Is it all the above?
Probably all the above. I mean, even going back to the question about research, in Trevor's case, like there's no evidence or research that says, well, here are the range of motion and weight bearing restrictions for someone who tore all these structures, because that it seldom happens in that combination. So even like these weight bearing restrictions are a complete guess. I mean, and that's something too. You said if we had more data, like I'd like to know, like how much can we really hurt people if we have them weight bear early and mobilize them early? Because I think we're trying to be very, very safe in the grand scheme of things. Maybe it doesn't matter, but immobilization is one of the most destructive things you could do to somebody. And some people, even like in equal cases, are a little bit more restrictive with that kind of thing. And, from a professional deference standpoint, we're always going to, the constraints from the surgeon, if they say these are the range of motion limitations during these weeks, we adhere to that. And then everything else, as far as we're concerned, is fair game. We work around that, but we don't really know. There's no, like, again, really definitive way to say, well, this is what's going to happen if we do this. It's a lot of trial, but I think we need to do more investigation in that area about like weight bearing and the influence on healing. But to really answer your question, the biggest thing is just, does it look good and does it evoke their symptoms? And if it doesn't evoke symptoms, like if they don't give you the pain face and it looks good, we progress to the next thing. We're not making huge, macro level jumps, and we're never going anywhere near, especially early on, like anywhere near failure or the limit of their output. So we're always operating at like a 70, 80% level of, being conservative, nowhere near the limit. So even in that case, if we overreach a little bit, we're still not near the limit and we just progress very slowly. But I think, again, this can be very overwhelming, but if you just look at it like, no matter who you're working with, if the end goal is the same, the process is the same, but for the early constraints and just getting people to do things that look good and don't exacerbate symptoms. And if you can do that, then rehabbing an FAI surgery is not that much different than an ACL, and a Tommy John's not different than a rotator cuff. Early on, there's different constraints, but then it's just, you go off, does it look good? Does it hurt? And are you adhering to whatever, healing timelines or constraints you were given by the surgeon? And then it's just applying those same principles.
Excellent. Greg, anything to add on there?
Yeah, that, like, just piggybacking off that, like, does that look good is a hard thing, right, to quantify. Sure. Or to kind of put some like guardrails on or whatever. So for us, it's that does it look good is something as simple as, for NCL, do they have a straight leg raise straight the entire time? Like, that's a very simple application of does that look good, versus like if we have that same ACL person maybe a few weeks later and they're squatting, it's like, are they caving in? It's like, that also doesn't look good today, but it's just applied to the specific task at that point in their entire protocol or their entire rehab. That was just, like, we're given constraints. Maybe they're kind of based off of older principles or more traditional application of the research that we have available to us, but it's also a risk reward thing too. So it's like, yeah, Doug, just mentioned it'd be nice to have some research on after meniscus surgery or whatnot. And it's almost like well, if we already know, like, it's going to take this long to get to a certain sort of milestone physically, like, does adding a week of weight bearing initially right after surgery, does it really push the needle, or does it make the world of a difference? Like, maybe it does, maybe it doesn't, but it's always just back to like a risk reward thing. And I'll always at least tell my students, our physical therapy students that we have, do clinical rotations with us, I'll always tell them, like, do a little bit less than you think you can, because you're then functioning under that sort of threshold, and your coach's eye can say, okay, this looks good and it's kind of adhering to this protocol, and I could probably do a little bit more, but it's not worth it, because this is a one point in time and we have time, and I don't want to blow them up for the next week just because I wanted to see what I can get out of this person for my own sort of ego, or like just to see how far I can push myself with the athlete.
We always say with our athletes, leave one rep left in the bank, right? You're not a power lifter, you're not an Olympic lifter. Optimal versus capable, another Ian King, right? You might be capable of doing that, but your form might look like what. Let's slow it down. Great points. Trev, I want to bring this back to you. So Doug, Greg talked about the difficulty, not the difficulty, but does it look good? That's hard to quantify, right? Do you quantify anything in this process? Are there KPIs or anchors that you use? Is it a force plates metric? Is it a combination of the eyes, the progressions, and XYZ metric, specifically with this case?
I do use the Hawkins force plates very regularly with all of my athletes. I use it more, I would say, like in the mid to later stages, to help me understand, like, from a strategy standpoint, is there something that I'm missing that I want to work on a little bit more? Like, if somebody's really asymmetrical, you can kind of tell that with your naked eye. If their, eccentric deceleration is not as good as I think it is, that gives me some measurements, for that kind of stuff. But really, it's I think Greg kind of brought it up. It's like the progression can happen really quickly. In the case of an ACL, like, it's usually weeks, but the progression would be the same whether or not somebody is in a post-op case. The progression would just happen a lot quicker. So if they can do a straight leg raise and their knees bent, well, then I'm sticking there until I'm going to start doing maybe some open chain stuff or something more loaded. If we're doing just a body weight bilateral squat and it looks great, awesome. If I give them a 25-pound dumbbell and it starts to look like crap, then okay, cool. We're not going to, do a counter movement jump today. So it's really understanding the progressions of like forces and time and impulse and velocity that allows us to have a really systematic progression of easy to hard. And like, I mean, there's days where it's like, okay, you did your box jump looks great. Okay, well, let's add like a 6 or 12-inch depth drop to that. And that's still safe, but it's a harder activity. But we did that just after one set of box jumps because I'm like, it looked so easy. It looks low effort because, we're always assessing. Like we've talked about it before, how it's like testing. We think of testing as like one day of testing. It's like every day we're with somebody is a test. Every rep that they do is a test. And I'm watching them and assessing them, their movement competency, how hard, how stressful does it look to that individual. So, there's just so many things that we're going to look for. Like when I'm doing our extensive plyos in somebody's warm up, if somebody's keeping that knee totally locked as they're, doing some easy pogo hops or, some sort of extensive double leg plyometric, it's like, well, I'm not going to go to some single leg plyometric until that looks better. Because I understand that the ground reaction force is going to be much higher just by taking away that, uninvolved limb. So having a really good progression of whatever activity it is, whether it's your squat progression, your jumping progression, your running progression, your cutting progression, whatever it is, having that progression of forces from easy to, kind of medium to kind of hard is really, really important, because I think a lot of times people make that jump from easy to hard without experiencing the stuff in the middle. And that's when the kind of, the wheels fall off a little bit.
Understood. What is the final step of this clearance process, specifically for this case? I saw some awesome videos. I'm going to rob and steal from you guys, and specifically though that you can explain them a little bit more in terms of the dynamic kind of one-on-one battles that I know that's a much more dynamic end stage type, focusing on quads, everything, sports specific context. But when is that final? How do you in your mind say, wow, that individual right there, we've got all the requisite jumping progressions, lifting progressions, he or she is ready to rock and roll, back on the ice with a skills coach, or, back on the football field?
For myself, it's, can they do stuff that kind of resembles the sport in some capacity? And I cannot replicate practice. I can't replicate 21 other guys being on the field and running around against press coverage and timing of a ball and all that kind of stuff, right? But I can replicate like him running as fast as he can with the flying 10. I can replicate him changing direction with some of the different kind of, tag type games that we play. I can replicate him having to fight through an opponent and, with some of those hip battles and underhook fights and grappling variations that we got from Andy Rowland that we can do. So we cannot replicate the complete demands of the sport, the velocities, the intensities, the forces, but we can get kind of close. And if we're kind of close and we're putting them in situations where they can't think about the knee, they just got to be able to react and play, I think we can get a lot closer to understanding what that athlete is actually kind of capable of handling. Because I've seen a lot of kids that don't go through some of those, higher intensity sprints, change of direction, agility work, some of the grappling stuff. And then it's like, then you get put on the field and all of a sudden fear kind of kicks in because you haven't done it. Like you're just not prepared for it. It's like that's showing up to a test that you haven't studied for. Like you're not going to be confident going in a test that you haven't studied for. So I'm just trying to get my kids as prepared for the test of practice of games as they can be.
Any other comments, gentlemen, from that clearance question?
I would just add, I mean, if you watch some of those videos, like Trevor's one of the few people who can, without a warm up,
my ass off in those videos.
Like without a warm up, he can literally, do combative stuff with a Division I football or, like a high level athlete. He's doing some of those grappling drills. Like again, no warm up. He didn't do the progression the athlete did. Like he just decides like, well, this guy's ready for some grappling drills or we're going to play tag today with someone who's really athletic and fast. So
look at the team though, boys. Look at the team. Look at the team though. Look at these guys, lean, mean machines, baby. You guys can do it with any of them. Look at you guys, tip top shape.
Skin in the game, man. He's taking risk. He's risking his own body with these athletes.
I'm sorry, I interrupted you, Doug. You were onto something. I was commenting.
I'm just saying, like, the athlete's taking risk, but so is he.
I want to respect everybody's time. Greg, I'll shift this one to you. Please piggyback. Where can listeners find more about you guys in general and educational materials?
Yeah, our website is resilientperformance.com. We just recently actually had a brand new one built out, kind of be a little bit more internet friendly and kind of meet the standards of what the algorithms and Google enjoys. So we had that built out a couple months ago. And that's going to house anything that's more like brick and mortar for us and our physical therapy business and working with us in person. And then for any of the educational material that we've had put on the internet and courses, we have two different courses. One's our movement foundations course. It's more of like how do we take you from movement preparation through like the weight room and performance exercises and along that continuum. And also there's some stuff in there, kind of scratching the surface on running and sprinting and some other things. And then we also have a course that Trevor created, our acceleration and agility course, return to sport. And there's also other small resources that are available as well. But that's all housed under our old website, which is slightly hidden now, but it's edu.resilientperformance.com. So essentially anything education related is like edu as an education.resilientperformance.com. There is a link in like our regular website that says like professional education. You can click on that, but it's kind of hidden because we want that website to be more so focused on patients that want to work with us in person. But that's where you can find anything that's education related.
Outstanding. Doug, what's next for the team?
So we're writing that book for human kinetics. We're hopefully going to be done with the first draft of the manuscript like around the holidays, and then editing process. So maybe anywhere from 8 months to a year from now, that'll be on the shelf. And then just trying to continue to develop students through the internship program, and then try to make ourselves accessible to more locations that are interested in the kind of model that we provide.
Excellent. Our guests today have been Doug, Trevor, and Greg of Resilience Performance Systems. Gentlemen, thank you so much for joining us.
Thank you.
Thanks, Anthony.
Thanks for having us.